Hello and welcome to Decentralized Health Administration at the Ubrica Project. My name is Dr. Mashari Wawengi. I bring you technical knowledge about creating perfect conditions for much needed revolution in the health industry. Under these new conditions, universal health access will be possible. Everyone in the world, including you and your loved ones, will have access to the best health services available. Health for everyone will be of the highest quality there is in the world, and it will be affordable by all, including that chicken that is making noise in the background. Well, we live in natural environment. We have chicken, we have dogs, we have what other noises do you hear? You can hear hyenas, you can hear birds in the air, and that is not a bad idea. It's just that we celebrate nature right where we are here here at 1.4 degrees south of equator and 37 degrees east of the central meridian. So as you enjoy the natural noises, you will find that we are going to be having fun today. And today I have great things to discuss with you. Great things, and we're going to take a little bit of time because we want to understand, number one, the fundamental problem with centralized architecture of global health administration. And then we are going to go straight to discuss about the solution which it can be found in systems thinking. And this information is coming to you from Decentralized Health Administration textbook under development by Susan Nyambura Njuguna in Ubrica Research Project, Research and Development team. But first, let us visit the basics of the Ubrica project. We have said many times over, and in this button we keep saying this, that Ubrica project strives to solve three fundamental problems of health production in the world. The first problem is that of lack of access to health services. The second problem is the poor quality of medical services. And the third problem is the high cost of medical services in most of the world, particularly here in Africa and in Kenya, where we live. Now, lack of access to health services occurs when people do not have money to go to the hospital. Of course, money is very important. If you don't have it, you won't even have food to eat. So that lack of money itself obscures your access to health itself, not just health services. The other problem about access occurs when there is no hospitals to go to. And of course, we in Africa, we have a huge shortage of hospitals and people do not have clinics near them. Many people have to walk for miles, let's say 5-6 miles. That could be about 10 kilometers to get to the nearest medical center. That is not right. Then the second problem we said was a poor quality of medical services, and poor quality occurs when good knowledge to deal with medical problem is unavailable. Why is knowledge unavailable? We shall see that. And then, of course, the third problem in health is the high cost of medical services in most parts of the world, particularly here in Africa. In fact, in Kenya, medical care is so expensive that if you go to India, you will get medical care at a tiny fraction of the amount of money you pay for medical care in Kenya. And why does this occur? These kind of things can occur. High cost of medical care can occur when manufacturing of products that can be used to improve health is stifled. We have very limited manufacturing, of course. If we were to be asked, we would say we don't have any manufacturing of medical products in Kenya because we don't have factories to make medicines, biomedical devices, and other products that we would use in hospitals. Now, we solve the three problems. Number one, the problem of access due to lack of money by creating Sokojanja. Sokojanja.com, spelled as Sokojanja.com, an online retail store where everyone can sell what he or she has produced to increase their earning power. Money in the pocket means realized access. So having an online store is very good. We call it Sokojanja.com. Ubrica clinics and hospitals project ensure physical access. As we said, people can lack access when there's no hospital or clinic nearby to go and get medical care. What about the quality itself? Ubrica Science and Technology Parks create places for translation and commercialization of new and relevant knowledge, ensuring best quality of medical services in the world. And that's really great. And then finally, the Ubrica Biomedical industrial setting promotes local manufacturing of biomedical products, reducing the cost of medicines and medical devices, and even health services in general, making healthcare affordable. So we have to build a very, very big biomedical industrial city right here in 1.4 degrees south of equator, and then we have the capacity for reducing cost of medical care. How are we going to do this? We have created Ubricoin, UBN. UBN, that's a symbol. The cryptocurrency is a cryptocurrency for universal health access to underwrite health production in the Ubrica ecosystem. How do you participate, or where do you come in? You can support universal health access in the world by getting and adding Ubricoin to your portfolio of cryptos, or by getting equity in the Ubrica project. Just get involved. Stop asking too many questions. Do not sit on the sidelines of health. Let us decentralize this health. And you can even get deeper, more involved by joining the World Ubricoin Ambassador Program. We call it WUAMP, World Ubricoin Ambassador Program, where you gain deeper knowledge about Ubrica Project and continually share that knowledge with people in your circle of influence. As an ambassador, you will be the bridge between Ubricoin, Ubrica, Sokojanja, and the people in the world. So that is about the Ubrica project. I hope that you have understood, and we shall maybe say it again before the end of this presentation. Now, to support us, hit the like button to cement your support. You can hit the bell button so that you can receive notifications from the Ubrica project, and or participate in the chat at the bottom of the video. And then you share your views on how we can decentralize knowledge in health and medicine. In today's news, we said that we are going to talk about the fundamental problem with centralized architecture of global health. This is heavy duty material, so listen carefully, because you're going to talk about a solution that is in systems thinking. What is systems thinking? We're going to learn all about that. And again, I told you this material comes from the textbook that's under development known as Decentralized Health Administration by Susan Nyambura Njuguna in Ubrica Research and Development Team, and her team as well. So let's dive deep into the fundamental problem. We say, while it is fanciful to imagine that we can sense from a centralized organization changes in health environment in all communities in the world, in order to gather vital statistics, global health conceived as public health has no sensory component. That is to say, global health itself as an entity has no feeling. Indeed, global health has no capacity to sense what events are happening in remote communities in the world. And as a result, we have projects designed that end up being disastrous. Absence of sensory organs such as pain receptors, on a human body, means that the body cannot detect changes in the environment. For example, if you don't have pain receptors, you don't sense pain, and so your body cannot react to pain. If you have put your hand on a hot plate and you don't have pain receptors, you will not feel pain, but you will start burning your hand. Similarly, Global Health Administration lacks capacity to gather local knowledge. When it lacks capacity to gather local knowledge, it doesn't have capacity to detect emergence of diseases. Then the disease then progresses to form an epidemic. It is only after the disease has killed a significant number of people that now do we hear about that an epidemic has occurred. In some cases, the disease spreads very rapidly undetected, traveling to distant parts of the world, and that is when we call it a pandemic. And all this is happening because Global Health Administration does not have sensory component, or the architecture itself cannot sense diseases when they are about to happen. Blockchain technology is well suited to reach billions of people. Constant data gathering, machine learning, artificial intelligence algorithms, they can form a complete sensory component for the Global Health Administration. And this means that right now, we have the technology to create sensory components or sensory organs for global health, such that we can detect data using artificial intelligence, machine learning, and then we put that on blockchain, and we can detect diseases before they emerge to forestall occurrence of epidemics. Now, here's how systems thinking could help. So in the absence of systems think, in the absence of sensory component, we're not able to gather intelligent data about health from local people. In these circumstances, it is not possible to know with certainty the reality on the ground. The only data available to help formulate decisions about global health comes from snapshots of reality, a snapshot of reality. So much of the information needed to make sound decisions is missing. So we tend, in this scenario, we tend to concentrate on fragments of reality of health concerns on the ground. Fragments of reality of health concerns on the ground. This obliterates our ability to see the entire system. Interventions built on fragments of reality end up worsening the condition they try to solve in a typical fixes that fail system archetype in systems thinking. Such solutions never generate long-term sustainable results. Now, what is systems thinking, you may ask? Systems thinking is an approach to problem that asks how various elements in the ecosystem of health production influence one another. Rather than reacting to individual problems that arise, a systems thinker will ask about relationship to other activities within the system, look for patterns over time, and seek root causes. At its core, systems thinking is aimed at seeing how things are connected to each other with the whole entity. We often make connections when conducting interpreting research or our professional practice. Anytime we talk about how some event will turn out, or the event, whether the event is an epidemic, a war, or other social, biological, physical process, we're invoking mental model about how things fit together. However, rather than relying on implicit models, it is with hidden assumptions that have no clear link to data. Systems thinking deploys explicit models with assumptions laid out that can be calibrated data and repeated by others. The word system derives from the Greek word sunistanai, and that's a cause to stand together. A system is about things that are standing together. A system is a whole of parts that interact towards a common purpose. Systems thinking is intended to improve the quality of our perceptions of the whole, its parts, and the interaction within and between levels. Now you can see if we don't have systems thinking, then what we call global health or health administration is not going to work. Now, the problem is that we have made decisions about health in the world without systems thinking. And many decisions we have made about health or global health are centralized to a handful of international organizations and US government agencies. Key organizations contributing prescriptions about what to do in global health include number one, the World Health Organization. We have discussed this before. We also, number two, we have the World Bank, we have the United Nations, we have the Global Health Office at the US Agency for International Development and the like. And of course, very many international development agencies. But you can see these agencies are big organizations found where in European countries, maybe in the United States and Canada, and that's it. Then that is where decisions are created and they're given to us here like prescriptions. The way when you go to the doctor, you are sick, the doctor doesn't bother tell you what's going on, but gives you a prescription. So in this vertical centralized architecture, global health decisions are executed through ministries of health of member countries of the United Nations General Assembly. So the current centralized health administration architecture excludes local people. That means people like myself and the other people living in this country, in Africa, in Kenya. They are excluded from contributing what they know about diseases that affect them. Local people automatically become fringe stakeholders who are powerless and voiceless. And this is why we are here, so that we can bring power and voices. We can enable the voices of the local people so that the local people can participate. We learned from Gilder in 2013 that if we exclude knowledge that is residing among local people, we thwart learning and we hinder the emergence of elements of surprise from the local people. Whenever you stop knowledge from flowing, you hinder the emergence of the element of surprise. It is in the element of surprise that you get innovation. because people are surprising. They come to you with surprising results. But the centralized health administration architecture does not allow the element of surprise. Let the local people surprise you. Where do these surprises come from? They come from tacit knowledge, the knowledge that is in the local people's heads, but you cannot get that knowledge unless you talk to them, unless you ask them what they know and listen to them using deep listening. Thus, in the centralized health administration architecture, we have a massive blind spot which creates a profound learning disability. And this learning disability is the cause of what we see as poor health outcomes across the board in all developing countries, and even in many developed countries. For example, we still do not have universal health access, even in the United States. A health administration architecture that has a learning capacity requires us to think how to engage local people so that they would participate in creation of their own wealth and production of their own health. Knowledge is wealth. If we inhibit local knowledge from emerging, then we don't have the wealth of creating solutions to the health problems. And of course, we get epidemics like Ebola, we get epidemics like cholera continuing to go on in this African continent. Local people do not get a chance to participate in decision making or even contributing knowledge about their own health. Data used for interventions about outbreaks and health threats do not come from the affected people. It comes from prescriptions written out by some people out there, maybe in Geneva, or in New York City or Washington, D.C. The impact, consequences, interventions, and cost of mitigation measures often come from outsider organizations based in high income countries. This is a major blind spot regarding the risk, consequences, and the nature of intervention required in the low and middle income countries. When the power of local people to make decisions about health is shifted upward to centralized groups in the international development community, a shifting the burden system archetype kicks into play, as local people are denied opportunity to participate in contributing knowledge about matters that affect their own health. Now, we learned from Peter Senge in 1990 in the fifth discipline that shifting the burden is a very bad problem. The resulting solutions never generate long term. The resulting solution do not generate long-term sustainable positive results and only worsen the condition in the long run. More resources are needed to cure the initial problem and the side effect of the short-term solution. So the cure is worse than the disease. Why does this happen? Because shifting the burden causes decay of local knowledge. Shifting the burden has got three loops. If you read the works by Peter Senge in 1990, in the fifth discipline, you will find that shifting the burden archetype has got three loops. There are two balancing loops, one on top of the other, and one side loop, which is a reinforcing loop. In order for you to understand these loops, you have to read about systems thinking and how the system archetypes are described. So on top, we have a balancing loop. That means it occurs when a foreign organization sees an increase in the incidence of a disease, say like in malaria. So when a malaria shoots up, the international organization, say the WHO, says, let us go there and reduce that incidence. Yeah. Usually, when the international organization comes in to reduce the incidence of that disease, the local people step aside to watch from the sidelines as members of the international organization administer their prescribed solution. For example, in 1998, Rollback Malaria Program was created by the WHO, and the WHO came to Africa after seeing the rise, a peak in incidence of malaria, and so they came to distribute insecticide-treated nets. They talked about indoor residual spraying and then giving anti-malarial tablets to the people to fight the increasing incidence of the disease and maybe death due to malaria. Following that intervention, the incidence of disease and death reduced slightly for about 3 years and then began to rise again. It shot and peaked once again and it overshot the previous incidence. Why did this happen? Because there was no local knowledge. As soon as this happened, the loop that was saying the top balancing loop, increase incidence, knockdown with treatment, the incidence reduces, and then it picks up again. Now, that is typical fixes that fail system archetype in systems thinking. Now, let's go back to our shifting the burden. We said it has got two loops, a top balancing loop and a bottom balancing loop. So the bottom loop represents the fundamental solution working in a decentralized architecture to generate local knowledge about how to deal with a disease. For example, if it was malaria, when the incidence went up, the local people would have done something, which they usually do, to keep the malaria down, particularly if they were enabled with money, if they were financed. Instead of the WHO going to buy mosquito nets and tablets to come and distribute in the village, the people in the village should have been the ones to create that solution, and that would form the bottom loop. But you see, uh, the when there's an intervention from outside, the knowledge about how to deal with the problem in the bottom loop begins to decay. So people unlearned what what they used to do about malaria when it came to them, and because of that, there was a decay in local knowledge. And of course, what happens next as an outside loop kicks in, which which tries to cover for this absence of knowledge or this decay of knowledge that is inexorable. Now, you know what happens is that in a fundamental, in the bottom loop where we would have the fundamental solution, people would have taken the local insecticides such as pyrethrum. Pyrethrum contains pyrethrin, and pyrethrin is a natural insecticide that kills mosquitoes. A mosquito is a natural carrier of plasmodium that transmits malaria. But WHO did not think that way, and so of course, the reinforcing loop kicked in, which the side effect of the symptomatic solution on the top loop and multiple iteration of the top loop now cause in continuous atrophy of local knowledge on how to deal with the local problem. So pyrethrum was abandoned, and the local people do not know what to do. They are sitting on the sidelines of these interventions, and this repeated atrophy of local knowledge led to eventual decay of that knowledge and worsening of the original problem. And malaria continues to kill people to this date. So in this case, repeated atrophy of local knowledge led to an inexorable increase in the incidence of disease, disability, and death due to malaria. This traditional way of practice of global health is both incomplete and unsustainable. Traditional approach shifts the burden of knowledge creation about the problems from the local people to an international organization. The international interveners abduct, you could say, they take away the role of control and eradication of disease from local people. The local people in turn step aside to allow international interveners to enter. As the local people step away from solving their own problem, their traditional knowledge about how to solve local problems beginning to decay as outsider intervention continue, and traditional local knowledge held by local people decays exponentially and ultimately disappears. This inexorable decay and complete disappearance of local knowledge is a major side effect of outside interventions from a centralized system. This is why it's very, very important that we have to decentralize health administration so that such unintended consequences from shifting the burden do not occur. Now, shifting the burden leaves a gap between what is achieved and what can be achieved. Evidence shows that people continue to die due to poor quality of health and inability to pay for health care. A comprehensive method of addressing both access of and quality of health and health financing is key to achieving global health. The system requires deep thought and about how to solve shifting the burden resulting from centralized architecture. Deep thought, ladies and gentlemen, deep thought. And now we know that with the new technologies, distributed ledger, we have the blockchain, we have cryptocurrencies, they're going to help us reimagine and redefine the architecture for global health administration. Now, unlike the traditional architecture dominated by highly centralized hierarchical organizations, everyone has opportunity to contribute knowledge in the decentralized architecture. Due to blockchains accessibility being distributed and censored and uncontrolled, it is most fitted to ensure universal health access that doesn't have blind spots like shifting the burden system archetype or even fixes that fail. Finally, let's return back to the basics. I hope that you have understood that section. We can discuss this more and we continue diving deeper and deeper into this discussion so we can know how best to decentralize healthcare, particularly with knowledge from those who came before us, like Peter Senge in his book, The Fifth Discipline, the art and practice of the learning organization. When people fail to see the problem in the architecture, then they can have a learning disability. And of course, we want to have systems that learn. And of course, there's nothing better that can help us learn than a decentralized architecture of the blockchain itself, because it can help us reach very, very deep. Again, at Ubrica, in the Ubrica project, we strive to solve three fundamental problems of health production in the world. One is lack of access to health services. The other one is poor quality of medical services, and then the high cost of medical services in the world. We say that we created Soko Janja as an online retail store where anyone in the world can sell what he or she has produced to increase earning power. Money in the pocket means realized access to healthcare, and then we have Ubrica Clinics and Hospitals project to ensure physical access to health services. The Ubrica Science and Technology Parks create places for translation and commercialization of new and relevant knowledge, ensuring the best quality of medical services in the world. And then the Ubrica Biomedical Industrial City promotes local manufacturing of biomedical products, reducing the cost of medicines and medical devices and health services in general, and making health affordable. Ubricoin, the cryptocurrency for universal health access, underwrites health production in the Ubrica ecosystem. You, you can support Ubrica Health universal health access by getting and adding Ubricoin to your portfolio of cryptos, or by getting equity in the Ubrica project. Get involved. Please, please, let's work on this job. It's very big job of decentralizing health. Do not sit on the sidelines of health. It doesn't matter whether you're in rich or poor country. There's major inequalities across the board. Whether a wealthy nation or in just a country that doesn't have much money like Kenya, let us all get involved, and we together we can achieve global health. You can get even more involved by joining the World Ubricoin Ambassador Program, where you can get deeper knowledge about the Ubrica project and continually share that knowledge with people in your circle of influence. As an ambassador, you'll be the bridge between Ubricoin, Soko Janja, and the people in the world, and that's really important. So we we urge you to continue working with us. This is very important that we crack this idea of decentralizing health. You know that in manufacturing, in computer science, in engineering, we have managed to decentralize even distribution of knowledge. What we have never been able to achieve in is we have never been able to achieve a distribution of knowledge in medicine and healthcare. And knowledge in medicine and healthcare is concentrated in very few centers in the world. And as you can see, when it comes to global health, we have only few organizations such as the World Health Organization, the Global Health Office at the United States Agency for International Development, and of course at the United Nations itself. And these are not enough. We are more than this organization can handle, and we have got more disease and more diversity of diseases and disease processes than any of these few organizations can handle, and their prescription does not contain knowledge from local people. Thank you once again for hanging out with me. I will we'll get back tomorrow and talk about much more issues. As we wait, review this video carefully, and of course smash the like button so that we can know that you're there. Also post comments at the very bottom of the video, and then we are good to go. Thank you. Goodbye.